Good afternoon, everyone, and welcome to today's webinar on learning from rare events infant mortality data. My name is Lee Forbush, and I work at the National Institute for Children's Health Quality, also known as NICHQ, and this is the second webinar in NICHQ's Infant Mortality Expert Webinar Series. Please note that because of the size of the webinar, we will have all participants muted for the duration of the webinar. We encourage questions to be asked through the chat box function. You'll see there are two different boxes. There's a Q&A box and a chat box. We do encourage you to use the chat box. We will have a few minutes at the end of the webinar for a question and answer session with the presenters. So please do chat your questions throughout the webinar as they come up, as we hope to be able to answer several of them at the end of the call today. We're also encouraging everyone on the webinar to receive their audio through the computer rather than the phone. If you're experiencing technical difficulties with your audio, please call Heather, whose number is listed on the slide, for additional technical assistance. And with that, I would like to turn it over to Zandra Levesque, a project director at NICHQ, to introduce today's speakers.
Hi, everybody. Good afternoon for those of you on the East Coast, and good morning for those of you joining us from the West Coast. I'm really excited for today's webinar, and then that our wonderful improvement advisors on the infant mortality coin are here to share appropriate methods to support looking at infant mortality data. So first, we have one of our senior improvement advisors, Lloyd, Provost. He's an advisor associate in process improvement and helps organizations make improvements in their products and increase organizations' capacity to continually learn. He's been an incredible advisor, teacher, and close supporter of NICHQ, especially on the infant mortality coin, so we're really appreciative of his time today and helping us find different ways in which we can look at data. And then we have Tricia Finnerty, who is our Associate Director of Improvement at NICHQ, and she is one of our improvement advisors on the infant mortality coin, and she's provided leadership and expertise in the areas of design and implementation of quality improvement projects, and has just been of great support to our teams in the Safe Sleep Learning Network, risk-appropriate care, as well as pre- and early-term birth. So I'd like to welcome them both, and thank you in advance for sharing your expertise with today's audience.
And with that, we'll hand it over to Tricia and Lloyd.
Great. Thanks so much, Dee and Lee. Well, good afternoon, everyone. It's so great to see so many of you on the call and interested in this topic. So our objectives for our call today are to review the use of statistical process control, or SPC charts, for infant mortality data, specifically which SPC charts are most effective for small numbers and rare events. We'll describe how to make and interpret these charts for small numbers, known as TNG charts. I'll learn some of the ways these charts might be most useful for learning, particularly when stratifying data, and then finally identify ways to use small numbers to identify progress and improvement as a result of IM coin activities. So our agenda is to just briefly review some of the limitations of the current method of analyzing infant mortality data. We'll provide an overview of statistical process control and then dive into SPC for rare events. We'll show some examples and recommendations for applying TNG charts to infant mortality, although hopefully you'll also be able to think of some applications for other MCH data and programs. So to start off, why are we talking about small numbers and ways we might need to be looking at this data a little differently? So despite the U.S. having one of the highest infant mortality rates, for many states, infant mortality is a rare event, particularly when you start looking at certain causes of death. And then even for some larger states, when you go to stratify infant mortality by race or geographic region, which is really extremely important for enhancing our learning and our understanding of the impact of our programs and services on different populations, the numbers are obviously even smaller. In order to protect confidentiality and comply with state regulations, many vital records offices suppress values under a certain number and also do not calculate statistics on any numbers that are less than 20 due to the large variation that we can see with small numbers. And then finally, control charts, which we'll talk about shortly, and are another way we can be looking at infant mortality data, are not as effective for rare events. So we're just going to start briefly with talking about how the field is currently looking at infant mortality data and dealing with some of these issues around small numbers. So we know that final data analysis and reporting from state vital records offices and the National Center for Health Statistics can have a lag of up to 2 to 3 years. In terms of analysis that is done, data is often reported as a comparison between 2 points in time, and then also in order to make statistically robust comparisons, particularly among subgroups with smaller numbers, rolling averages are often used. And then, as I mentioned, various levels of aggregation or suppression are often employed to meet statutes protecting confidentiality. So these are just some examples of what I just mentioned and how infant mortality data is currently displayed. So the top left graph here, you see trends over time using 5-year rolling averages. The table on the top right shows the percentage change in infant mortality for each state between 2 periods of time, 2005 and 2013. The map here of the U.S. shows the degree of percent change in each state between 2 time periods, 2005 and 2007 to 2012 and 2014. And then this bar graph shows the infant mortality rate by Hispanic origin, again comparing 2 points in time. And the problem with some of these methods is that utilizing retrospective, aggregate, and suppressed data can really hamper quality improvement efforts to reduce infant mortality. So, a central tenet of quality improvement is using data in real time to evaluate the impact of programs and inform our decision making. And the time lag in accessing this data can pose a real challenge to that. And then strategies like rolling averages to smooth trends can limit our ability to learn from variation. And I'm stealing this metaphor from James Moses at BMC, but using these methods for quality improvement is sort of like driving a car using the rearview mirror only, and we're sort of ignoring the road ahead of us. So we want to offer an additional framework and set of tools and demonstrate how application of statistical process control methods to infant mortality data can really enhance data analysis and quality improvement efforts, particularly for rare events. So improvement efforts, we're making changes to our processes and our systems and looking for improvement in key measures. But we know that some level of natural variation exists, and we expect to see that variation in the data. But as opposed to smoothing that variation, what we'd like is tools to help us interpret that variation and be able to distinguish between that natural variation that we expect to see and variation that might be due to something else like our improvement efforts. And we want to be able to detect that change quickly to inform our work. So control or Shewhart charts are one tool that we use to help us interpret that variation and answer the second question in the model for improvement. How will we know that a change is an improvement? So they're going to give us feedback in as real time as possible about the changes that are being tested. Developed by Walter Shewhart at Bell Labs in the 1920s, so these charts have been around for a while. Control charts are graphs of data, typically over time, but other sequences of data are possible. They're going to include a plot of data over time with 3 additional lines. So we have the center line, which is the average of the individual data points, and then upper and lower control limits, which establish the bounds of system performance based on common causes. And we set these at 3 sigma from the center line. And control charts help provide a method to distinguish between 2 types of variation that we see in a measure, common cause variation and special cause variation. Common causes are those causes that are really inherent in the system over time. They affect everyone working in the system and affect all of the outcomes. While special causes are those causes that are not part of the system all the time. They do not affect everyone, but really arise out of specific circumstances. And we're going to take different action depending on the types of variation we have. So here you can see an example of a specific type of control chart called a U-chart. This is a chart for rate data. So this U-chart displays the quarterly infant mortality rate for a state from 2009 to 2015. And you can see here that the center line is a rate of 5.5 per 1,000 live births through Q2 2014, and then 4.6 starting in Q3 2014. And then the upper and lower control limits indicated by dashed lines here. And there are several different types of control charts, and the most appropriate one depends on the data that you are analyzing. So this is a nice flow diagram that walks you through the steps of which chart to pick. And I'm just going to focus on the two types of charts that we've used most often in the infant mortality coin, which are based on count or classification data. So in the case of classification data, we're putting each unit into one of two categories. So a woman smoked during her pregnancy or she didn't. An infant was born in an appropriate level facility or they weren't. And in this case, we make a P chart. When we're counting incidences as opposed to classifying, so as in, counting infant deaths, we're going to use a U chart, and that's the chart that we just looked at. Different types of data obviously have different underlying distributions, so normal, binomial, geometric, and the calculation of the sigma value and the upper and lower control limits are based on statistical formulas that are appropriate for the type of data being analyzed and the assumed underlying distribution of that data. So I'm not going to go into a lot of detail here, but the formulas for the calculation of the center line and the limits for those two charts, the U and P chart, are listed here. So the U chart based on the Poisson distribution, again, an example here would be our infant mortality rates. So SUID mortality per 100,000 live births. And then the P chart based on the binomial distribution, examples here being, percent of infants sleeping on their backs or the percent of women who stopped smoking during pregnancy. And again, I'm not going to go into a lot of detail on the formulas here, but we've included a reference slide at the end that has a lot of great articles for more details around this. So control charts really allow us to apply rigorous statistical methods while also preserving the time order of the data. And this allows us to look at and learn from variation over time as opposed to fixed points in time. And because we're looking at the data sort of as it's unfolding as opposed to waiting for aggregated sets of data, we're able to detect changes earlier, really expediting our learning and action. And then finally, control charts define and quantify what the process or system that you're looking at is capable of producing given its current design. And our job in interpreting a control chart is to understand the data well enough to be able to distinguish between a common and special cause variation. And there are probability-based rules that you can see here that we look for when interpreting control charts. So the first one is a single point outside of the control limits. So here you can see our mean and then the upper and lower control limits with two examples of points outside the limits. The next rule is a shift, 8 or more consecutive points above or below the center line. A trend, which is 6 or more consecutive points decreasing or increasing. The next rule is 2 out of 3 points near an outer control limit, and you can see two examples here. So here you have 2 out of 3 points near the lower limit, so they don't have to be consecutive points. And then this rule also applies to points on opposite control limits. So here, 2 points in a row, 1 near the lower limit and 1 near the upper. And then finally, 15 consecutive points close to the center line. And again, the purpose of these rules is to help us distinguish between common cause and special cause variation. And if we see any of these rules, it's an indication of special cause variation, and it should really be a prompt to ask good questions and learn about that, what might be causing that special cause variation. And using these rules really helps us detect signals of special cause as rapidly as possible while really minimizing the risk of over or underreacting to the patterns of the data. So this just shows some examples of special cause signals. So again, here we see quarterly infant mortality data, and you can see two special causes here. Q3 2012 with a point outside the limits, and then a second special cause, 16 consecutive points below the center line. And this is a comparison of the rolling averages data that I showed earlier from a state vital statistics report, and how that compares to control charts using infant mortality data over the same time period. So while there's, obviously more up and down variation in the control charts, the control limits and the use of the rules helps us interpret that variation and ensure that we're not over or underreacting to the data. So looking at the black non-Hispanic black data, the blue data series here, this looks like a downward trend. But when you look at the control chart, this top chart here, with the exception of the first data point, we just see common cause variation. And so using the rolling averages, we may see trends when none exist. The annual data also allows us the opportunity to learn from any variation that might be smoothed with the rolling averages. So for example, you're starting to see what could be the start of a shift in the non-Hispanic white data starting in 2010 using the control chart. So the control chart method really offers a consistent approach to deciding if something important is happening. The ability to learn from variation is obviously dependent on having access to all of the data. And so, suppressing data that is less than a certain threshold clearly presents a limitation to learning. So this top graph here shows the non-Hispanic Black quarterly infant mortality rate for a state with any deaths less than 10 suppressed. And you can see that we have missing data for several time periods here, and we see a mean of 13.9. We know that this is higher than what the true rate is because we're not including periods with lower numbers of deaths in this calculation. And the next two charts just show how the mean would change if we did have access to the data. So the second chart assumes 9 deaths per time period, which is the highest value that it could be. And using this most conservative estimate brings the mean down to 12.4. And then the last chart here, using a value of 5 for the suppressed time points, shows a mean of 9.9. And here, really just illustrating the importance of having access to the data to accurately learn about the system and take informed action, and that we have to use caution in interpreting these charts if there is suppressed data. So in addition to the limitations of suppressed data, we start running into problems with the typical Shewhart charts when we get to working with small numbers. So if the event of interest does not usually occur in the time frame being observed, we're going to be plotting a lot of zeros. In addition to limiting the sort of opportunity to learn from variation in the charts also become less effective for learning. So in order to develop a really useful chart and limits, we want to see less than 25% of the values at 0. Having a lot of zeros also results in a calculation of a lower limit that starts becoming less than 0. And, in the case of infant mortality, when we want to see rates go down, the lower limit helps us detect improvement. So not having a lower limit limits our ability to quickly detect improvement. And obviously, you can increase the time frame for reporting periods to address these issues. So, if you're collecting monthly data, you can move to quarterly. If you're collecting data quarterly, you can move to annually. But this lengthens the time that we can look at the data, really slowing down learning. So there are two SPC charts that are particularly useful for rare events. These are the geometric, or G chart, and time between, or T chart. And this table just shows some of the more advanced control charts that are available. Again, we'll just be focusing on the T and G charts for rare events. So these are alternatives to the P and U charts that I've been mentioning. And they measure and plot either the time in the case of the T chart or opportunities in the case of the G chart between an event of interest. In our case, infant mortality. And because we want longer periods of time between deaths, higher values are going to represent improvements. And one of the advantages of these charts is that you plot a data point each time an event occurs. So rather than waiting for a standard period of time, like a quarter or a year, these tools allow events to be studied as they're occurring in real time. And while these charts haven't quite made their way into regular use in healthcare and public health, we do see lots of examples of this concept in everyday life. So construction sites often have signs that indicate how many days they've gone without an incident. Every day they update the sign indicating that another day has passed. And you can see the picture on the right here has both the current number of days since the last incident and then also the longest time they've gone. So for the T chart, we are plotting time between an incident. And as I mentioned earlier, in plotting infant mortality, we make the assumption that the data are modeled after the Poisson distribution. But for the T chart, if we're looking at time between events, that would follow an exponential distribution. And the problem with the exponential distribution is that it's highly skewed. And so plotting the times would result in a chart where we wouldn't be able to apply the special cause rules, which is really important for our learning. So in order to calculate the limits here, we have to do a transformation of the data to a more symmetric distribution by raising the time measure to the power of 0.277. We then transform the limits back to the original time scale for display with the original data. And you can see, again, the calculation of the control limits there on the slides with additional references later. The difference here is that the limits are not going to be symmetric when we come back to the time scale. So the lower limit is going to be closer to the center line than the upper limit is, and we'll see this in the examples. The second chart for rare events is the G chart. Here we're plotting the number of cases or opportunities between the incident of interest. And here, instead of just knowing the time between, we also need to know the opportunities for the event to occur. So for the last case of retained foreign objects, we would need to know how many surgeries were done. In our case, looking at infant deaths, it's usually how many births did we have. And the way we calculate the limits here is based on the geometric distribution. So for the center line, we take the average number of opportunities and multiply that by a factor of 0.693, which is going to give us a theoretical median and will give us a center line that's in the middle of the data. There is no lower control limit on a G chart, so while it does allow us to see improvement, it is a little harder to see if our system is worsening, so important to use in conjunction with other charts. And we've been really excited about these methods and how they can be, how we can be using them in infant mortality, and we have been working with a few states to learn more about how we can be really applying this to infant mortality reduction efforts. So I'm going to turn it over to Lloyd now, who's going to go over some of the examples that we've been seeing. And Lloyd, I am going to pass you the ball.
Okay. Thank you, Tricia. Great. Very good introduction into the SPC methodology, and then also the argument about why we need to consider these more complicated charts. So we're used to seeing the charts where on a regular basis each month or each quarter we summarize our data and plot it. That's the appropriate P charts and T charts. But the problems we see when we emphasize in the IM coin work of a key strategy for learning from our data was stratification. And so we encourage people to break down their data by region, by cause of death, by race, by if they're looking at the data, used to looking at the data quarterly, look at it monthly. And so as we did that, all of a sudden we're running into the small numbers. And Tricia did a good job summarizing the two key problems there is we don't have a lower control limit, so we don't see, if we have improvement, we're not going to see it immediately. We're going to have to use some of the other rules to let the signal accumulate. And then two is often we're plotting zeros. The usual control charts, if anytime more than 25% of the data is zero, then the methodology breaks down. It doesn't give us accurate portrayal. And so the alternatives we have here are the T and G charts. So during the last year, we've had a number of states that have tried out these charts and worked through how they would use their data and actually calculate the charts. And I want to share a few of those today to do that. Places that we see the biggest applications are, first of all, some of our smaller states. When we've asked them to look at data monthly and sometimes even quarterly for particular types of deaths, we end up with very low numbers there. And then, as I mentioned, the stratification there. So we'll see some examples of race and ethnicity, some geographic. We look at it by regions of the state, by cause of death. We looked at a SUID chart earlier, and maybe by age, every age there. So those are some of the ideas, and you might want to think of some others to do that. So a lot of times our limitation, when people have good ideas, I really like to break this data down and look at what happens when we segregate it by this. And though when they try that, all of a sudden they say, oh, well, we don't have enough data that, you know, on a full aggregate basis we could learn from. When we start stratifying, it makes it more difficult. So think about some of the other possible applications as I show you these. Okay. Right. So we have a chance to come back and ask some questions about those, and I think some people have done that, and we'll pick those up in a few minutes when we get in the question and answer period. But just to summarize our key ideas here, the T charts and the G charts are alternatives. So I said we want to use SPC methodology to look at data over time. We run into problems with zeros, too many zeros and no lower control limit. Here's our alternative. The T chart's readily available. All we need is the date of the death, so people would have that immediately on their hand. The G charts require to quantify your data system, so we're actually keeping track of how many cases between. So if we go into the records, I think most state records have it, but you actually have to do a little algorithm to count those up and keep track of how many births between each death there. Is that complication worth it? I think so. As you can see from, I think, each of the examples we showed, that always the G chart was more sensitive. We have a lot more information. The T chart, we're just assuming time's going on. We're not thinking about how many births took place. In G chart, we're using that information on how many births took place, so it is more sensitive. And I think the states we work with in general felt like that was going to be a more useful chart with them once they figured out how to keep track of their cases. The advantages of these charts is we can actually learn from the variation. We're not plotting zeros. We can see that now and keep us from overreacting and underreacting. The charts are more sensitive than the U chart because we have that lower limit, and we're seeing improvement. Just the opposite. They're not as sensitive if things get worse. The U chart's going to pick that up quicker because it has the upper limit there. I think the main thing the chart does is break down that barrier and encourage us to do stratification, to advance our learning and not just report our overall state numbers, but start thinking of it by region, by race, by cause of death. Okay. And then the other part is when we worked with the states, we tried to identify some of the special cause signals on their chart. Special cause signals were back in 2012 or 13 or 14, and the people that were involved had difficulty. We didn't know about what were the events going on, what were the special things. But if we get in the habit to start using these charts as a regular way of reporting and learning from our data, then we'll have a timing analysis, because each time we have a death, we automatically would update and plot our data point, and we would then real time be able to say, okay, it looks like something special is going on, and I think we'd have a much more better chance of identifying and begin to learn about the special causes that could impact our infant mortality. There are some limitations on the chart. I just mentioned the no lower control limit, so that just don't throw away our U chart. We'll keep that as a regular way. Tricia mentioned earlier the problem with the suppression of low numbers there, and I think we have to kind of work that out. What does that mean when we're plotting data each time to do that? And I think that runs us in some issues there. So I guess one thing I've learned is the problem with suppression of data is, I think, if we're really trying to learn from our data and learn to improve, we need to kind of review our rulings and strategies on that so that we can maybe do a lot better of being able to learn from the data, but still not run into any issues that would be created by using each data point. The other thing is everybody's not ready to use these charts right away. It takes a little education and training. What we saw in the states that we work with on these, they very quickly picked up the concept, especially after they took their data. When you're looking at other people's data on the charts, it's harder to learn, but once you look at your data on the charts and start asking questions, I think they picked up the methodology and understood that quite easily. And then we are plotting data as soon as it becomes available, so that means the first data is going to be provisional data. So often on these charts, we'll have updates as we get additional data comes in, new data comes in. So sometimes the data for the last 5 or 6 data points could change on us on a regular basis, and we have to just be aware of that and thinking about that. Our recommendations based on our work with the states is all states should think about their data reporting systems and see how they bring SPC capability into that. They could automatically, when they generate reports, some of the methods now, the rolling average in particular, can be very misleading. Rolling average is done because we're saying, well, we don't want people to overreact to the variation. The advantage of the control charts is we have a method so that we don't overreact. We have limits there to tell us when to react and when not to react. The rolling average is actually, people see trends in those and directions, and actually they're not real trends. They're autocorrelation based on doing the rolling averages and the combination. So it's the rolling average chart appears to be simple, but it's actually a very complex chart to learn from. So I think SPC capability can really help us say, let's don't hide our variation by averaging it. Let's look at it and learn from it. States should have expertise at the state level, and they're certainly the epidemiologists that work at each state and others that be able to explain in the SPC methodology for others in the organization and in the reports. And then for the rare events, anytime we want to do stratification, think about using the T and G charts there. And lastly, how can we get where we're learning from special causes in real time? If I think about an action plan, is how do I get the capability to start reporting these as a regular basis, and then what's the appropriate way to begin to stratify these so that we looking at different strategies, and then what is our methodology to learn from the special causes when they are there? Who's triggered to take action and actually participate in the review and learning, so we start identifying some of these things that actually have either a positive or a negative impact on infant mortality. So, Tricia, I'm going to, before we do questions, I'm going to turn it back to you just to talk about the resources a little bit.
Great, thanks so much. So as I said, I'm just going to quickly share some resources. So, we know that control charts may be a new tool for many of you or for others who you might want to be sharing this methodology with. So we did develop a one-page introduction to control charts that is available on the NICHQ website. So I encourage you to go download that. You know, obviously this was just an introduction to statistical process control. You know, we hope that this piqued your interest and you'll go learn more about the theory, the statistics, and the applications. So this is just a list of references both on general SPC and then specifically on TNG charts. And then, you know, fortunately there are many programs now that have options for creating these charts. So statistical software programs such as Minitab, SAS, and R do have options to create SPC charts. There is specific SPC software that you can purchase, such as Chart Runner. There are also several Excel add-ins that are available, such as QI charts and QI macros. And as Lloyd mentioned, you know, ideally you want to be creating the charts in your current reporting system to really sort of ease burden and increase the chances of using these charts as much as possible. So I think I'm going to turn it back over to NICHQ to ask any questions that we might have gotten.
Thank you so much, Lloyd and Tricia. Wow, there's a lot to learn about TNG charts, but we're so glad to have this really thorough introduction and to have all those resources where we can learn more. I'd like to be able to open this session up for questions from the audience. So if you haven't yet had an opportunity, please feel free to chat in any questions you have for the speakers. We hope to get to most of the questions, but maybe not everyone's due to time constraints. Our moderator for this portion is Sandra, and so I'm going to turn it over to her to ask a few of the prepared questions that participants actually submitted in advance of the webinar, and we'll go and continue on with some live questions as well.
Thank you both. That's always, even though I've listened to your workshops and your talks many times, I always learn something new, so I really appreciate it. And you are getting many kudos from the audience. I know you're, unfortunately, this time around, you cannot see the chat box, and you probably find it most helpful due to the large number of the participants. However, let's get started with the first question that was submitted in advance of this webinar. And one of the participants was asking if you could share what are useful databases to access infant mortality statistics.
Sure, this is Tricia. I can take that. So the state vital record offices, as we mentioned, really have the most up-to-date infant mortality statistics, and you know, most of these have moved to more real-time, and as Lloyd mentioned, provisional data. So you know, the access to that in many states is getting better. And then the State and Territorial Exchange of Vital Events, or the STEVE system, is new and currently available through NAPSIS, which is the National Association for Public Health Statistics and Information Systems. And this is a system that allows for the electronic exchange of vital events data, and so that's been really helpful for sharing data among jurisdictions, and I believe they're at the point now where different partners can sign up. You know, it's a process to do that, but there is more information on the NAPSIS website, and then you have access to the vital stats data as it becomes available. So we can, Lee or Dee, maybe we can put the link to that in the chat box.
We can, because the chat box is not public for this one around.
Oh, right, sorry.
Yeah, but we'll include it in the next steps when we send out the follow-up to this call, so people can have access to it.
Habits die hard. I'm used to the chat.
And then we have another question from, this one comes right from the chat box. There is a question around an understanding of why suppressing data leads to problems, but they just want to understand why you would suppress data in the first place. Is this a common way of reporting something like infant mortality?
Yeah, so suppression is typically due to different state to state, but based on, you know, state regulations or statutes that limit the data that can be sort of publicly available to protect confidentiality. So, you know, if there are fewer than a certain number of deaths in a time period, there are concerns that those people could be identified. And so in order to protect confidentiality, numbers under a certain threshold, again, different for every state, are suppressed.
And I see that there's another question So the person who asked us, thank you so much for that explanation. That makes a lot of sense. And then also there's a question around more resources on dealing with small numbers and suppression rules. So to our audience who may we urge you to look at the resources that Tricia just presented towards the end. And if there are additional questions you may have, by all means, please always feel free to send the questions to us here at NICHQ. We'd be happy to support you.
Yeah, and also the NCHS and NAPSIS website also, I think, have a lot of information on sort of suppression and how that is dealt with as well.
Thank you. And let me make another call out to the audience. Are there any additional questions?
This is Lloyd. In the chat, I do see a question about the lower limits on the T-chart. And the reason that occurs is when you actually do the calculation in the transformed data, the calculation of plus or minus 3 sigma comes up a negative number. And so when you transform that back, there's no, it can't be transformed. So there's essentially no lower limit there. So it's the mathematical exercise of calculating the limits actually results in a calculation that can exist, therefore there's no local control limit. And then the G-chart, by definition, does not have a lower limit from the geometric distribution.
And there's another one for you all, too. On the U-chart, are your confidence limits measured by standard deviations or confidence intervals?
Well, yeah, the limits are called control limits, and they're a little bit like the concept of a confidence interval, except the confidence interval is around the data point, and these limits are around the center line. So it makes the statistics behave quite differently. But Tricia defines the limits based on Walter Schuhart's work called 3 sigma limits. So they're a sigma calculated from the data, or sometimes a theoretical calculation, but it's not the usual standard deviation. So it's a methodology to include only common cause variation in that variation, not special cause. And so it's different than the usual standard deviation. And the way that's done is different for the different types of charts. And I think you have to look into the references to look how each type of chart accomplishes that using 3 sigma limits.
And I'll just note that the Muhammad article in the references, the tutorial notes for healthcare practitioners, goes into a lot of good detail about the formulas and calculations that might be helpful there.
And we have quite a tall order in the questions, too, about somebody, and guys, in case you have any high-level advice on how to use SAS for these, if there's any could you point them to how T-charts could be done in SAS? Is there any resources that you could point the listener to? I know that's quite the question.
Yeah, this is Lloyd. I've used SAS in the past, and they did not have this capability in their SPC module. Possibly they've added it. I don't know. I know some others, like Minitab, has added it recently. Chart Runner has the capability. So SAS could do it. And then, of course, if you have people that can program in SAS, it can very easily be programmed, just using the formulas in the reference. So it becomes part of your SAS reporting system.
Great. Thank you so much. I just wanted to take a moment and say thank you to you both, not just for today's webinar, but the incredible amount of advice and guidance you provided to the teams on the infant mortality coordinator around this very challenge. So thank you. And at this point, we'll go ahead and wrap up our webinar.
Thanks so much, Sandra, and thank you all for participating today. Our next expert series webinar will be on August 31st at 2 o'clock, and it will focus on the role of state health leaders in addressing neonatal abstinence syndrome. We hope you all can join us. And of course, we want to give a big thank you to Lloyd and Tricia for your guidance and your expertise today. And we want to let everyone know that upon exiting this webinar, you will be taken to a quick survey that we hope you can complete about your experience today. So thank you, everyone. Have a great afternoon, and this concludes the webinar.
Thank you, everyone.